Jaime Sepúlveda, Executive Director of DTHF. This session is being recorded, and this is the first of our grand rounds for this year. We have a wonderful speaker. I'm going to ask Dr. Craig Coyne to introduce our grand round speaker. I had the chance of talking to Andrew Medina-Marino, who's actually a New Yorker with a South African accent. That's a very interesting combination. So Dr. Craig Coyne will introduce Andrew as a host of these grand rounds. Craig, as you all know, is a professor of OBGYN. He has been working in Africa for decades, mostly in East Africa, but also in South Africa, doing wonderful HIV work. So we're very proud and privileged to have Craig as part of our team. So no further ado, Craig.
Thank you, Jaime, for the nice introduction. So it's really my pleasure to introduce Andrew Medina-Marino, who is both a friend and a colleague for the past 5 years, friend more recently. Really an amazing researcher, originally from the US, trained at Caltech for his PhD. And then he was an epidemiological investigative EIF's office.
Epidemic intelligence.
Epidemic intelligence. Yeah, I don't have the intelligence part. Officer at CDC and did outbreak investigations around Ebola. And then he moved a little over a decade ago to South Africa with a focus in the Eastern Cape province, which is a place that until March I had never been to before. Most people who go to South Africa go to Cape Town, Western Cape province, go to Joburg and go to Durban. And maybe a few other areas as a tourist, but not to work. And he's there because of his mission, and he'll be able to talk with us today about his focus on at the intersection of tuberculosis and HIV. He also is building a program around men's health and their unique susceptibilities to health and disease. And we'll focus a lot. We'll also talk with us about his focus on building local capacity. So he has a primary appointment at the Desmond Tutu Health Foundation, and he also has an adjunct appointment at the University of Cape Town, as well as an adjunct faculty appointment at the Perelman School of Medicine at the University of Pennsylvania. So he has a lot of other accolades, a lot of grant funding, mentees, and he'll be talking with us today about his work. So Andrew, over to you.
Morning. Thank you very much. Okay, so today I just want to tell you about some of the work that we're doing around TB diagnostic testing and men's health specifically. Before I get into that, I just want to give you a quick orientation to South Africa. So South Africa has 9 different provinces. I'm sure everyone has heard of Cape Town, Johannesburg, and Durban. Those have traditionally been the main centers in the country. Regarding South Africa and HIV and TB, so South Africa just did its first TB prevalence survey, and in 2018, they found a prevalence of 737 per 100,000 population, which makes it the highest prevalence in the world. When you look at individuals age 15 and older, it jumps up to 825. So this is very significant. 58% of those TB patients who are initiated on ARTs, 58% of those individuals with TB also have HIV, and only about 50% of all individuals with TB successfully complete treatment. Regarding HIV, obviously it has the highest HIV absolute number of individuals. 7.9 million individuals are estimated to be living with HIV in South Africa. It has a general population prevalence of 14%. Amongst those aged 15 to 49, it jumps up to 20%. So these are very serious health indicators in the country. So when you think about where all the great research is typically coming out of South Africa, you always think Durban, Johannesburg, Cape Town. Those have been the historically advantaged research centers. And I bring this up because I'm going to speak later on about some of the work that we're doing to build capacity in Eastern Cape. regarding Eastern Cape, so all the work that I'm going to tell you about today, we've done in Eastern Cape. Just to give you some picture of Eastern Cape, so of South Africa's 9 provinces, it ranks last in its human development indicators. It has the 2nd highest HIV prevalence in the country, and it has hands down the highest TB prevalence, ranging around 1,236 per 100,000. It has some of the poorest health metric outcomes for HIV, TB, maternal child health, and health service delivery. And by far, it probably has the least amount of mature research infrastructure. Okay, so the Desmond Tutu Foundation, it's originally had sites in Cape Town. That's really where its home has been. But in 2017, we started building a site in Eastern Cape, specifically because we wanted to ensure that there was the type of research capacity in the province to allow communities in the province to contribute their voices to the international HIV/TB kind of clinical trials. As many of you know, the clinical trials for PrEP were done back in 2005, 2008. PrEP only came to Eastern Cape in 2018, but in places like Durban, Johannesburg, Cape Town, it showed up a decade earlier. We also moved there with the mission of ensuring that key public health issues are researched, and that we provide targeted interventions for the communities in Eastern Cape. And also, as all research, good research should, to provide information to the health department in order to develop their interventions and to do resource allocation. Okay, so moving on to the more scientific part of the talk. So I wanted to talk to you about TB globally and in South Africa specifically. So obviously, until COVID-19 happened, TB was the leading cause of death globally. In 2020, there was an estimated 10 million cases of TB, of which 5.8 million were diagnosed, meaning that there's a very large gap in the number of cases that have been missed. In 2020, 1.3 million people died from TB, and that's actually up from 1.2 million in 2019. This is around the impact of COVID. And for those living with HIV, 240,000 individuals with HIV died of TB, and that was up also from 2019. So you see this impact of COVID, which I'm not really going to talk about much, but that's been the impact in South Africa. So ultimately, 4.2 million cases of TB were not diagnosed or reported. So this is what's typically called the missed cases of TB. Usually they're called missing cases. A lot of people say, well, these individuals don't even know that they're missing. So this is really about the healthcare system missing the diagnosing of these individuals. Okay, so this is just a map of the estimated incidence of TB in 2019. And you see in the yellow circles, the low burden countries, North America, Europe, Australia, and then the regions of the world that have the high burden of TB, with sub-Saharan Africa being disproportionately impacted. So just to give you an idea of the difference between high and low burden countries, so this gray line represents the global burden of TB. When you compare the global burden to the United States, the United States back in 1990 to 2019 goes from 12 cases per 100,000 to about 3. When you look at South Africa, it's a marked difference. And obviously the curve starts to significantly increase when you start to see a lot of TB HIV co-infections happening in the country, and the curve starts to go down, which is concomitant or consistent with when ARTs were really started to be rolled out in the country. So one thing that these curves do is they mask the significant gender disparities in TB, and they also mask the large proportion of missed cases of TB. Ultimately, the global burden of TB rests amongst men. In 1998 was the first time that the global TB report actually showed data that men had a higher burden of TB compared to women, but it was only in 2013 that the global report actually stated men had a higher burden of TB. So for those intervening years, there just really wasn't much focus. And frankly, there hasn't been much focus even since they started saying this. In 2019, adult men in the world accounted for 56% of all TB cases, whereas adult women accounted for 32% and children 12%. So you could just see the significant burden of TB disease amongst men. So this is a very nice picture to just get that visual of what's going on. So what you're seeing here is in the boxes outlined in black or gray, that's the total estimated number of TB cases. And then the cases in purple are women, those in green are men. Those are the cases that have actually been reported. So the difference between the green or purple box compared to the white part of the box, that's the estimated magnitude of missed cases. And so you could see that men account for a much larger portion of those cases that are missed. Approximately 70% of the global missing cases are assumed to be amongst men. And this definitely speaks to the idea that women seem to have better access to diagnostic services, they have better access to diagnostic services. Men, you could say, are potentially not benefiting from the gender transformative responses that seem to be happening, especially in HIV. And this also speaks to the need to do interventions or to develop interventions and implement interventions that are probably much more gender responsive than they are now, at least in the context of TB. Just in case you might have thought that, oh, there might be some outliers that is drawing this, outliers in terms of countries, that the burden amongst men seems to just be pulling that number out. Actually, in all the national TB prevalence surveys between 2007 and 2018, all of them showed a higher burden amongst men compared to women. And the lowest ratio was 1.2 cases in men for every 1 in women in Ethiopia to a whopping 4.9 in Vietnam. Okay, so TB and men's health in South Africa. So TB in South Africa is responsible for a large portion of the differential life experience between men and women. For those who are living with HIV, TB is calculated to be about 81% of that 11-year life difference. And for those without HIV, it's about 43%. Men are more likely to be delayed in their access to testing and care, die while engaged in care, and be lost to follow-up after initiating treatment. And the South African National Prevalence Study that happened in 2018 showed a prevalence ratio between men and women of 1.62. Okay, so just to visually drive home the point of what's going on in South Africa. So this is publicly available data. This is the absolute case counts of microbiologically confirmed TB amongst women, and this is amongst men. So 62% of all cases of TB that have been diagnosed in South Africa are amongst men. So obviously, as public health folks, we want to look at things as a per 100,000 population. So when you look at the national data, the prevalence of TB amongst women is shown in this graph broken down by age groups. The black dotted line is 1,000 cases per 100,000. When you look at men, it's significantly higher. This is at the national level. So the reason why I circled the x-axis here is because I just want you to keep an eye on this, because this axis stays consistent. What I'm going to show you next is what's going on in Eastern Cape. So when you look at what's going on in Eastern Cape, this is the burden of what's going on at a provincial level. But then when you start to break it down to different districts, you see different profiles going on. So in Buffalo City Metro, this is what the prevalence profile looks like. So it skews slightly towards younger folks, goes down over the life course. When you look at OR Tambo district, you see the burden increasing amongst men throughout the life course, where it exceeds 2,000 per 100,000, which is just a unforgivable number for men age 55 to 64. When you look at another district, this is the Port Elizabeth district, Nelson Mandela Bay district, you see how it skews much younger, and then it goes down over the life course. When you look at another rural district, you see And again, going over the life course, increasing over the life course, and it tops out at about almost 2,500 cases per 100,000 for men age 55 to 59. When you look at Sarah Bartman district, which is another rural district, this has the highest prevalence of TB in the country. And you see that starting at age 25 all the way through about 59, it exceeds 2,000 per 100,000 amongst men. Now, it's not to say that women aren't having a serious problem, because these numbers are horrible regardless if it's men or women, but the difference between men and women is quite stark. Okay, so given the global burden of TBs amongst men and all of these gender disparities around testing uptake, diagnosis, treatment outcomes, we were thinking, okay, we need to identify an intervention, whether we adapt the intervention to try and understand, or to try and implement something that will decrease these gender disparities. And the first thing we did was we found this great systematic review meta-analysis, and we thought, okay, here's going to be the perfect place. We'll identify the interventions that seem to work better for men, and then we'll adapt them for the South African context. Ultimately, what it showed was that DOTS was better than doing nothing, which I'm not a believer in DOTS. Treatment reminders. So it broke down all these interventions amongst these 7 different areas for adherence intervention supports. So we did a deep dive of this one paper, and we looked at all the papers that were published after 2005. What we saw was, of the 129 papers reported, so published after 2005, only 76. The big problem is that only 17 of these papers stratified their results by gender. So that's already a big problem there, where 76 papers and you only find 17 that are stratified by gender. When we took those 17 and looked at which of the papers that showed significant improvement in intervention versus control, we found 13 papers. But of those, in 8, men did better than the control, but women still did better overall. In 5 of them, there was no treatment effect for men, meaning that the intervention purely worked for women, not for men. And thankfully, in none of them did men do worse than the control. So at worst, this uneven reporting of sex disaggregated results is perpetuating and ignores gender disparities. At best, the poor reporting of sex disaggregated results made it difficult to identify interventions that you would then say, okay, let's take a step back, let's adapt it for the South African environment, and let's implement it and see how it goes. Okay, so it's at this point that we said, okay, we probably need to take a step back and try and understand, what are men saying that they want and need of an intervention to support them to stay retained and engaged in TB care. So this study was, it was a small R21, and we had 2 aims. One was qualitative investigations to really get at understanding what men and women were saying they were wanting, such that we could really differentiate between what are unique things that men are saying, what is everyone saying, and what are women saying that they want. So we could really target gender sensitive, gender responsive interventions for both men and women. For the purpose of the talk today, I'm just going to talk about our qualitative work. So this was a prospective study. We recruited individuals who are currently on TB treatment, those who recently completed treatment, and those who are lost to care or exhibiting behaviors that would put them at risk for loss to care. And what that meant was we tracked individuals and identified when they had missed 15 or more days of when they were supposed to come back to pick up their medication refill. We did this in 15 different clinics throughout Buffalo City Metro Health District. We did in-depth interviews, and the behavioral framework we used was called the Network Individual Resource Model. I could explain that later, but just to put that out there. So what we did was we recruited upwards of 500 individuals, and then we followed them until they had the outcome that we were looking for. So ultimately, we conducted 180 qualitative interviews, which is quite a massive amount of work. This was broken down evenly amongst those currently in treatment, recently completed treatment, and those who were showing behaviors that would put them at risk for being lost to care. We also interviewed 48 key supporters, and we are in the process of doing focus groups now. Okay, so to give you a quick case study of a man that was part of the study, So let me tell you about this guy. His name is Odwa. He's a married man with 2 kids. He works in a scrap metal company near the airport. Odwa started to get sick 6 months ago. In his interview, we asked him about how his illness affected his work. And what he responded was, it was mostly coughing. At my work, I would work with a blade that's similar to the one that they use in a butchery. So I would be busy cutting a battery with one hand, and in the other hand, he had the blade. And he was coughing, so he had a lot of challenges doing his work. In the fuller interview, Odwa explained that he was not able to do his work safely, and he lost his job as a result. He went to the clinic and was diagnosed with TB and immediately started treatment. The treatment had been difficult for him since the pills made him more sick and because his family didn't eat at the same time that he took his medication. Also, he felt lonely and wanted to speak with another man who had TB. He thought that by speaking with another man, the other man would understand what it meant to be sick while having the responsibilities of providing for his family. And he said that this man could also help him to take his medication since he would understand the situation he was in. So one of the things that we kept picking up from men was they were speaking about wanting to have peer-to-peer support. I won't necessarily go through all of these quotes. I'll happily share the slides with you. One of the other things when we were trying to understand, so we were trying to understand what men were saying they wanted in terms of the content of the intervention and how they would want it delivered. And a lot of men were saying the best place to deliver this would be in male spaces. Lots of men were talking about, in a tavern might not be the best place to deliver an intervention like this. They were talking about delivering it where men congregate in the community, which, one man spoke about doing it where they were playing games. And the idea was that if you're invited by a man in that group, that you would have obviously you would have a lot more access, but you would be a trusted voice. One thing that we had some other men talk about was this idea of a crawl space. So in South Africa, a crawl is somewhat of a sacred space where men will engage in communications with other men around cultural activities in the community. And that would be a very safe space, but that's definitely one of those kind of culturally sensitive spaces that is probably going to be much more difficult to access, but that would be another kind of male space to look at. Men also very much spoke about being isolated in their feeling of a need for connectedness, and this will come up when I talk in another few slides. So the next thing we did was we started to compare what men and women were saying, and even though the interview guide didn't necessarily focus around stigma, something that kept popping up was the impact of stigma on their treatment experience. So obviously there were things that both men and women were saying that they were experiencing. Both men and women anticipated stigma. They anticipated having lost some relationships, being gossiped about. That was also another big one. The interesting thing about how stigma was impacting them, so obviously, both men and women could be saying that they were anticipating stigma, but how they reacted to that is the important part when you're thinking about what's the mechanism in which stigma is impacting their behavior. And what we were picking up was women were self-isolating before they had any an enacted stigma. So there's the anticipated stigma, someone is going to say something bad, the enacted stigma, which is someone actually does something to you that's stigmatizing, and the internalized stigma of, somehow I'm dirty or less than because I have TB. So we found that women were self-isolating in anticipation of being stigmatized, whereas men were being socially isolated by their families. So people knew that they had TB, and then men were being specifically isolated. So women were anticipating and sort of isolating themselves before anything happened. Men were being isolated. And so when you think about that mechanism of how stigma and anticipated stigma is impacting someone, it's important for how you think about developing your interventions. Let's see. Yeah, so ultimately, men seem to be more forced into isolation by their social network. Men were more likely to express a sense of social loss. And a few men actually gave examples of being isolated by their families or judged. whereas women showed a higher concern for negative judgment and then obviously self-isolated in order to not be put in the situation of being directly stigmatized. Okay, so I want to switch over from the more qualitative work that we've been doing and focus more on the quantitative diagnostic work. Okay, so again, when I was talking about missing cases of TB, so these missing cases of TB are a key driver of transmission. Of the estimated 10 million TB cases that occurred in 2020, about 4.2 million were either not diagnosed, not treated, or not reported. And the WHO recommends that in order to minimize the number of missed cases, especially where the prevalence is over 100 per 100,000, that countries implement systematic screening of individuals presenting to clinics and is specifically focusing on vulnerable populations. So that would be, right now would be considered, if you know that a man is a minor, someone who has HIV, someone who has a comorbidity that might increase the risk of TB disease like diabetes. And factors that are associated with these missed or missing cases of TB are an individual's health-seeking behaviors, structural barriers around access to health services, insufficient diagnostic sensitivity to detect TB, especially amongst those with HIV or children, and health system failures to identify individuals presenting to the clinic. So in many, many countries, probably the overwhelming way of detecting TB around the globe is, is passive case detection. So, someone comes in, they might come in with a cough, and then that's when they get screened. So there is also then active case detection, which is much more going out into a community, identifying households of TB index patients, doing screening there. The problem with household contact screening is many studies have shown that when you go to a household and you screen, do you have fever, do you have night sweats, do you have weight loss, do you have a cough? The overwhelming number of individuals who screen positive never take up their referral to the clinic. And we've done work where at most maybe 20% go to the clinic. And this is obviously without some sort of behavioral intervention, but you start to question, well, if you're only getting 20% of individuals showing up who are symptomatic, and amongst those 20%, an even smaller proportion actually have TB, you start to question the cost effectiveness of household contact investigations. Now, household contact investigations are obviously extremely important to do. I would definitely not say don't do it, but it's just how do you do it better? So these two quick slides. So in terms of the number of missed cases in South Africa, so I showed you this similar figure globally. This is what's going on in South Africa. So obviously, men make up the overwhelming majority of those cases that are missed. And when you think about the different areas of South Africa where those estimated missing cases are, Eastern Cape, yet again, has the, I don't want to say the worst, but it has the most number of challenges identifying TB patients. And it definitely contributes the most number of those missing cases to the national number. Okay, so the two studies that I'll quickly present to you, one was a study where we implemented household contact testing to see the acceptability and feasibility, and the second study was to do pooling of specimens, taking oral swabs and pooling of those specimens for testing. I'll get much more into this. Where we did this was, we did this in the Duncan Village informal settlement area of Buffalo City Metro Health District. And we did this in about 10 different clinics highlighted in the red crosses. So the two study devices that we used in the first study, we used a jerry-rigged GX1 device where we hooked up an external battery, and we did household testing. In the second study, the Omni device, if many of you know the Gene Expert Omni device, finally came out, and we used that. And then as we were doing the study, they said, oh, sorry, we're going to pull it from market. So we're back to using the jerry-rigged device, which is doing a great job, but it's definitely not as easy to lug around. Okay, so the first study is about acceptability and feasibility of home-based testing of household contacts using this mobile molecular point of care technology. So this was a pilot randomized control trial. We recruited TB index patients in the clinic, then went out to their households to screen households. The intervention was testing at the household. So, sorry, it was screening of the household of those who screened positive, testing those individuals, and then referring individuals for treatment if they tested positive. Whereas the control was screening at the household and referring for testing. We use sputum specimens in this study, and we use the Gene Expert 1 device. Just for some quick overview of the eligibility. So over 18, not currently on TB treatment, provision of individual written informed consent, of course. In the household screening, we screened household members using the basic 4 questions, and all individuals 18 and older were asked to provide a sputum. All the individuals that were younger than 18 who had any symptoms were immediately referred to the clinic for additional workup. So in terms of the patient flow, the quick of it is we enrolled 282 index patients. This represented about 1,070 household contacts. We screened 84% of those, which was a pretty good proportion of them. About 19% had TB symptoms, and 98% of those that we offered TB testing to in their home accepted testing. So this is saying, you know, it was a very acceptable intervention. This is a setup in the house. So obviously in many of the houses we were in, there was no real countertop, so we improvised. So in terms of acceptability and feasibility, again, 98% of individuals said, yes, you know, I'll accept a test if that's the randomization group that I'm randomized to. Of those that were offered testing, so that was 51 individuals were offered testing, we were only able to collect 24 sputum. So obviously there's this ongoing limitation of trying to use sputum for a specimen to test for TB. The big thing down at the bottom was that 95% of the tests we ran provided valid test results. So this is speaking to the feasibility of conducting home-based testing, at least in the aspect of, you know, getting the machine to work correctly in that environment. And so when we put our data into a basic TB cascade, so yellow is the intervention group, red is the control group. So we see that obviously in the intervention group, everyone was offered a test. Now in the control group is they're expected to present to the clinic, and of those who were referred to the clinic, only 15% showed up. And this is very typical of what happens. Of those who actually were tested for TB, obviously what's showing here in the intervention group where it's only 47%, that speaks to trying to collect a sputum. But for those who went to the clinic, there was one individual that they went and the nurse decided, oh, you're not sick enough, you know, come back, which is a serious problem. Of those who then actually received their test results, obviously by doing test results in doing testing in the home, you know, you're able to give someone their test results immediately. So for all practical purposes, 96% of people in the intervention group that got their test results, only 66% in the control group got theirs. So obviously we're starting to get down into small numbers. So there's not much we can make of this, but the trend is definitely there. One other thing to just mention is in looking at the time from screening to receiving test results, in the intervention group, it's obviously, you know, it was 0 days ultimately. But in the control group, it took up to about 16.5 days to get that, to get their test results. And in terms of those who tested positive and then were initiated on treatment, it took literally 1 day for people who got tested in their home to get onto treatment. And it took upwards of 39 days to get someone who tested, who went to the clinic to get tested to actually initiate treatment if they had TB. Am I 5 minutes? Okay. So let me jump to this last study. So what we did was we started to implement oral swab testing and compared that to sputum collection. The the sputum the oral swab testing was optimized in the lab, and we then started to implement that in the community. But what the next step unique thing that we did was we were pooling oral swabs into one household level test, because obviously if you're trying to test everyone in the household, if that's 5 individuals, the feasibility starts to decrease, because it might take you 4, 5, 6 hours to stay in that household unless you have multiple machines. So we were pooling swabs and comparing them to sputum. I won't necessarily go into this. So when we look at the sputum specimens testing in the household, we were finding a test positivity of 12.3%. So that would be 12,000 per 100,000 cases of TB in this area. I mean, this is an extremely high burden community. When we look at the positivity at the household level, we saw about a 4 or 5% positivity, but it's also because there were multiple individuals in a house that were positive. And so 4% of households showing up as positive is still rather high. Okay, so one big thing to just really point out is for all the individuals who tested positive and we referred them to the clinic, 100% of them showed up. So of the 20 people that tested positive, all 20 people went. The even more unique thing is they all showed up within 3 days. Like, that seems unheard of, especially when you're looking at the control of only 15% showing up, and it taking upwards of 3, 4, 5 weeks for them to get to the clinic. So in terms of intervention, home-based testing does seem that it could not only identify more cases the way active case finding should, but actual linkage to care. And this did not involve a behavioral intervention. This was literally you have TB, I'm really sorry, here's your referral, go to the clinic. So the fact that there was no behavioral intervention actually is quite exciting. When we start looking at the sensitivity, specificity, and predictive values of oral swabs to sputum, when we compare individual sputum to pooled swabs, we see a relatively low sensitivity, but the specificity was high, the predictive values were high. When we look at the individual sputum compared to the individual swab, we see excellent sensitivity and specificity and predictive values. And when we compare the individual swab with the pooled oral swabs, we again see that the sensitivity drops. When we looked at the result, when we looked at what's going on with the sputum, what we're seeing is all of these sputums had either low, very low, or trace amounts of TB. So what this is speaking to is more of a dilution factor issue with the pooled swabs. And so we've already optimized this in the laboratory, where we're showing, again, pooled oral swabs have upwards of a 95% sensitivity, 100% specificity when done in the lab. We're now starting to do this back in the community again. Okay, so last thing. So this is speaking to the capacity development that we're trying to do. So again, the historically advantaged research centers in South Africa, and us trying to focus specifically on Eastern Cape. So Craig and I wrote a D43, and we're hopeful that it'll get funded off the first round, called the Kulani Sipile Supuhle training program. And what this means is South Africa has 11 languages, and COSA, this means to empower and develop young researchers to help their communities heal, become healthy, and flourish. The institutional partners for this D43 are the Desmond Tutu Foundation, University of Cape Town, University of Fort Hare, Walter Sisulu University, and UCGHI. To specifically note, Fort Hare and Walter Sisulu are 2 of South Africa's 8 historically disadvantaged institutions, and University of Fort Hare actually notes Nelson Mandela and Desmond Tutu as their alumni. So it has a rich academic history, but obviously because of apartheid, the resources that were ever given to the institution were meek at best. Obviously, the training program is trying to address historic health and institutional inequalities, invest in institutions that are outside your traditional advantaged research centers of Joburg, Durban, Cape Town, and obviously also to create a cutting edge group of HIV researchers in Eastern Cape. We had proposed to train approximately 8 to 10 PhD students, and to also strengthen the faculty at these institutions. And the UCGHI faculty, what we're hoping to do is to partner at most 6 faculty from those institutions to partner with UCGHI faculty to actually write an R21 over a 2-year period and get that submitted. That's one of the indicators. And the idea is at these institutions, they truly have very little financial resources for research. And if you don't have those resources to set up research platforms, then you don't have platforms for your students to leverage. So that's a serious problem. And thank you very much.
Andrew,
That was a tour de force.
That was amazing. And I learned a lot as well. We've spoken mostly about capacity building and not as much about your research. So we're now open for the next 10 minutes for questions. We obviously have people in the room and we also have people online. I'm monitoring the Q&A session, so you can submit your questions online. I see a question from George. Also, I just want to say before we get started with questions, this is a reminder. So Andrew has many hats. One of them is he's our illustrious site PI in South Africa for the Global Health Fellowship. We're open for applications. Kimberly Bale, Deputy Director. We have Ali Mohammed, who's one of our Global Fellows this year from MUHAS from Tanzania. He's here at UCSF for the next 2 to 3 months or so, meeting him for the first time today. So if you know of anyone, or if you are someone who's interested in applying either as an advanced doctoral student or medical student, or as a postdoc, please talk with Andrew or talk with me or talk with him. All right, so George.
Andrew, thanks very much. It was a real tour de force. A couple of things, just as perhaps for the students who were just learning about TB. When you were talking about TB, you're talking about active TB, right?
Active TB disease,
Right.
correct.
Disease. And do you have any feel for what the prevalence of TB infection is in the country? And as a correlate, what the coverage of BCG is?
So at birth or soon after birth, kids get the BCG vaccine.
And is that, I mean, I realize it's supposed to be universal, but is it,
I think they do a pretty darn good job with that one. Yeah. In terms of infections around the country, they say, you know, upwards of 80% of individuals in the country have latent TB disease.
80.
I'm sorry?
80.
80, yeah. And there's a lot of global work that shows that the gender disparities for latent TB infection, it's pretty 50-50 men and women. So there's specifically something going on with men developing TB disease as opposed to just underlying latent TB.
Has anybody looked, you know, here in the early 90s when people started to look at with the sequencing, looking at TB outbreaks, it turns out that a lot more of it was very rapid onset TB. It was essentially primary tuberculosis rather than reactivation tuberculosis. Has anybody looked at that through South Africa? Because with you know, where you're looking at that, you know, the age groups, you know, here it's everybody's 80 years old with TB, and that's not true, but it's, you know, we have a very much older population with TB, which represents recrudescence, reactivation. What is it? Do you have a feel for how much of that's primary TB?
So I think, okay, so I want to say it's about 25-30% of individuals being initiated on treatment had a previous event of TB. So that recurrence, yeah, is about 30%.
Thank
you. Thank you for that.
Your story and your data. The reactivation pattern of TB, George, in most of the provinces, by looking at your youth bulge versus older population, shows you a lot of where reactivation versus primary TB goes. Most of it's primary TB is the clinical impression, especially if you look at like Anglo Gold, you know, populations of minors really show that clearly. And I think that the overlap with HIV was dramatic. Your 2010 slide showing prevalence of TB plateauing before, but then going down precipitously around 10 or 11 is really because the HIV platform started diagnosing and treating active TB, but also latent TB. And I'd never seen that aggregate number like that, but I do think that's most of it. But
Yeah.
thanks for that. Good
Yeah.
to see that.
Fortunately, I can't say South Africa has done a very good job of providing TB prevention therapy. They obviously do a better job of those who are HIV positive when they get initiated, but even there's some serious gaps. In terms of providing TPT to household contacts, doesn't happen.
I have a question, Andrew.
Yep.
So, I mean, I thought that your last study that you showed was really intriguing, looking at using oral swabs essentially in comparison to sputum and so forth. I'm just wondering if you could speak to around sustainability or scalability of that potential intervention. I know you have plans on that. Who were the individuals in the household that were actually implementing this household testing, either in the intervention and also in the control arm?
Okay, so who's implementing it? It was lay health counselors. Sorry, who's implementing it? Lay health counselors. Who's actually getting tested or screened in the household? Now, here's the issue: is, and I didn't show the breakdown of gender, but 60% of the individuals, 65% of all the individuals in the household are women. And if you're thinking about men being where the gap is, well, then household contact investigations probably really isn't getting at that bulk of missed cases, because we're showing that it's amongst men, but most of the cases we're identifying in the households are amongst women because, well, it's because women are still in the household. And so trying to think through what's the appropriate intervention to really target men for contact tracing, that's a whole other ball of wax. And I think we need to spend more time on that.
For the active case finding, for the active case finding, was there any screening for latent TB? Because, or is there like a second, like serial testing where you might a few weeks or months later catch people who were latent at the time?
Yeah.
Because it seems like it was for active TB, right?
Yeah. So we only do active TB, and because the prevalence of latent TB in the country is so high, it's almost pointless to even bother doing any latent TB testing. Really quickly, to go back to what you were saying, the sustainability of this. So in the National Department of Health's TB strategy, everyone is supposed to be doing contact tracing. It does not happen because the resources are just, it's quite massive. And you could see from, if you screen at a house and only refer for testing, if only 20% of people are showing up, it's just not cost effective. I think that our next study is obviously bringing this to a properly powered study, doing cost effectiveness assessment to see, is this something that we could really recommend as being a cost effective way of finding TB cases? Because the basic household contact screening and referral for testing, that's not going to cut it. So sustainability, let's see what the cost effectiveness says. Yeah, sorry.
Oh yeah, sure. The second question just has to do with sort of like the future of the Omni platform, the Gene Expert. We do malaria research, and we're really interested in low-level infections that are only detectable by molecular testing. And for decades, the standard has been microscopy, but so many more people have malaria that's only detectable by molecular testing. So the scale up, the availability of molecular testing is a major challenge. And if we can link up with, TB efforts, that would be great. But I'm just wondering what would have been just kind of some of the challenges, and what's like the status of that platform or other similar platforms?
The Omni platform has been taken off the market. Cepheid, for whatever number of reasons and excuses they have, decided to pull it from the global market. I think it partially has to do with they were going to be required to sell it to low middle income countries at the WHO rate, and that was never going to make it financially good for them. I would have thought that they would have run those kind of models before, but it sounds like that might not have happened the way it should have. So Omni is, at least in South Africa and low middle income countries, for the foreseeable future, it's off the table. And so that's why we went back to using the Gene Expert 1 device, and they have a modified one now called the Gene Expert Edge device. So it's a tablet computer. Instead of having to break out a laptop, and the battery isn't as clunky as what we had sort of jerry-rigged. The sustainability of it, if the numbers are good, if the cost effectiveness is good, then you could argue, sustainability, but otherwise we might need to think about a much more targeted way of utilizing it, because obviously we're seeing it definitely does work and acceptable and it's feasible.
So we're at the top of the hour, and I believe there's a class that's getting ready to come in here. I want to thank IGHS for hosting Andrew, and for Andrew coming all the way from South Africa. By way of Philadelphia. I also want to thank our listeners and our viewers online. This is going to be also on the IGHS YouTube channel you can watch. And if you're my kids, you'd watch it 2x speed. So thank you, Andrew. Thank you, everyone who's here today and online as well. Thanks.
Thank you very much. Thank you.